I'm going to be discussing in the first talk, it's going to be anatomy and pathology of the oropharynx. So let me just make sure I got my time set, and we will go ahead and start. So when we talk about the oropharynx, this lecture is predominantly going to be on the oropharynx. There are four primary subsites of the oropharynx, and they are the tongue base, the soft palate, the tonsil, and the posterior pharyngeal wall. Now, when you look at the oropharynx, really the way to think of it, it's almost like a box, and the anterior portion of the box is formed by the circumvallate papilla and the anterior tonsillar pillar. And you don't have to worry about this because we're going to go over this in great detail. The posterior margin of the oropharynx is going to be formed by the posterior pharyngeal wall. The superior margin is going to be formed by the soft palate. The inferior portion is going to be formed by these two little areas right here, which are the vallecula. And technically, there's a little fold of tissue that goes from the pharynx to the epiglottis, which is called the pharyngoepiglottic fold. So that's actually the inferior margin of the oropharynx. And then laterally, it's going to be formed by the various components of the tonsils. So like I said before, we're going to take a deep dive into the anatomy. And the prior two talks did a beautiful job in the anatomy. And one thing about head and neck radiology, if you don't understand the anatomy, then it's always going to be challenging. So the first here that we're going to discuss in the oropharynx is going to be the tongue base. So there are two components of the tongue. And this first component in the oropharynx is going to be the tongue base. And these little papilla right here referred to as a circumvallate papilla. And they are a V-shaped papilla, and the adjective that we use to describe this is referred to as a chevron-shaped papilla. And right at the apex of the chevron is going to be a little foramen, which is the foramen cecum. And this is where the origination of the thyroid gland begins. So when we have the thyroid anlage, if you will, this is where the thyroid begins, and eventually it migrates down into the final resting space, which, as you know, is anterior to the neck. Now, when we look at the tongue base, one of the common questions that we get is how do we know that we're actually in the tongue base? Because when we look at cross-sectional imaging such as this, we see some striated muscles that are running from anterior to posterior, and then we have something that's a little bit more posterior. So when we look at this anatomic section, these muscles that go from anterior to posterior are the genioglossus muscle, and we call it genio because they attach at the genial tubercle. And then Greek for tongue is glossus. So the reason we call this muscle the genioglossus muscle, it goes from the genial tubercle down to the tongue base. Now, if you look at this anatomic specimen right here, we can see that these tongue-based fibers are running from right to left, whereas these muscles are going from anterior to posterior. So when you see these anterior to posterior muscles, these indicate that you're in the floor of the mouth or the sublingual space, whichever term you'd like to use. But on the other hand, when you look at these transverse fibers that go from right to left, and you can see there's a lot of fat in it. Notice their lower attenuation, or I should say they're brighter here. They look more yellowish as they do a little darker reddish, and that tells us there's a higher fat content. So when we look at the tongue base on the CT scan, I think this nicely demonstrates the area where the muscle is. And then where a leap of faith, you can actually see these striations going from right to left. And that's how we know that we're in the tongue base. So when we're looking at tongue-based carcinomas, this is a schematic illustration of a tongue-based carcinoma. And we can see how it's located in the lateral aspect of the tongue base. And this is a CT scan of a tongue-based carcinoma. Now, as I mentioned before, the principles that we look for to properly isolate this in the tongue base, first, we see these striated muscles. These tell us that this is the floor of the mouth and this is the genioglossus muscle. But when we look at the tongue base, notice the low attenuation. And again, you can see these fibers going from right to left. So when you put your finger or your pointer in the center of this mass, notice right now you're in the posterior lateral aspect of the tongue base. And pure and simply, that's how I determine where the center of these masses are. Now, you can see the masses extending anteriorly into the posterior aspect of the floor and mouth, which is common for tongue-based cancers. And when we start talking about exactly what type of information is important for these tongue-based cancers, this type of information, this deep extension, is always important to mention in your report. Now, one of the things that comes up is there is this concept of the root of the tongue. Now, the root of the tongue indicates that tumors that involve this area really probably should not be resected with surgery. And the root of the tongue indicates, at least for me, that it's in close proximity to this nerve, which is the hypoglossal nerve. So this was a case that I saw, and you guys probably know, I actually see patients once a week. So we saw this patient in our tumor clinic, and basically we thought this was a 2-centimeter mass. And we thought, hey, is this patient can be treated with transoral robotic surgery? But when we looked at this, at the CT scan, we can see there's a lot of deep extension into the tongue base and a little bit of involvement here of the genioglossus muscle. Now, the other thing, too, is that these yellow arrows point at a specific artery, and that artery is the lingual artery. So anatomically, the lingual artery takes its origin from the external carotid artery. And there's a nerve right here that at the origin of the nerve is in close proximity to the origin of the lingual artery, and that's the hypoglossal nerve. So the point is, when someone asks me, where is this concept of the root of the tongue, different radiologists are going to have different opinions. But from my standpoint, over the last 30 years or so, and when I actually see patients clinically and we're trying to determine whether these are suitable candidates for resection, what I use for the root of the tongue is if I see a tumor and it's in close proximity to the horizontal segment of the lingual artery, then that tells me it's in close proximity to the hypoglossal nerve. And then if they did try to resect the tumor in this area, they would end up clipping the hypoglossal nerve, and that's not really a very good surgical outcome. So on the left-hand side, we can see a nice example here of the lingual artery, so I know the hypoglossal nerve is next to it. And in this case, we can see the artery here, and notice how this artery is encased and pushed by the tumor. And when we look a little bit more laterally, there's that lingual artery, there's the tumor, and I know the nerve is right next to it. So oftentimes I get asked for the root of the tongue is, and because this talk is on the oropharynx, I just wanted to make sure that I cover this specific topic.